So many thanks for the invitation. I'm grateful for being here for the first time in Cairo, and what a well-organized congress. Does it work now? Yeah. So it's difficult to come after Vicente, his excellent presentation. He's the master of anti-knee pain. And now one with a new battery. Great. So trochlear dysplasia is related to increased femoral anteversion, but so it's related, but this is all different. So yeah. And why is trochlear dysplasia of importance? It's of huge importance. Every knee surgeon should know about trochlear dysplasia. First of all, it's related to patellar instability, it's related to patellofemoral pain, and it's related to patellofemoral osteoarthritis. And we have to thank the anthropologist Tardieu from France. She told us why is human having a trochlear or sulcus when apes do not have one. So you see the picture of the chimpanzee. The ape has no trochlear, but what is actually ongoing here is that human has raised up. They walk with the knee straight compared to apes who walk with the knee bent and with a varus. So they don't have any huge forces on the patella. Humans, they have a lateralized tibiotubercle in order not to overstress the middle compartment of the knee, and in order to compensate for this huge Q force that acts on the patella, humans has developed this lateral buttress or trochlear slope. So trochlear dysplasia, that is a condition. It's not a disease. There are many patients who will never have any symptoms. Another thing is that there's no general accepted definition of trochlear dysplasia. So what is trochlear dysplasia? Yeah, it's a decreased trochlear depth, it's an elevated trochlear floor, it's increased bony volume in the proximal part of the trochlear, and in some cases it's more an undeveloped lateral femur condyle. And it's also important to realize that trochlear dysplasia is a continuum going from completely normal to very severe. And it's the most common or most predisposing factor for patellar instability. According to this study from US looking at cadavers, they found that there was severe trochlear dysplasia in about 5% of those cadavers, and mild to moderate trochlear dysplasia in 18%, meaning altogether 23% had some degree of trochlear dysplasia. We have just conducted a study on the Faroe Island. The Faroe Island is a small island with 34,000 inhabitants living very isolated and genetic isolated population, and they have church book going several hundred years back and DNA mapping. So now we are trying to find out if trochlear dysplasia is a genetic or heretic condition related to the DNA. But at 100 patients with patellar instability, and patellar instability is very common in the Faroe Island, the degree of trochlear dysplasia or trochlear dysplasia was found in about 32% of the population, depending on how you define trochlear dysplasia. It's different if you use the de Jure classification, if you use the lateral trochlear inclination angle, or if you use the trochlear depth. And I'm not aware of which way to define this that is best. There are these classification of trochlear dysplasia. They are all subjective. There are even more classification. And naturally, the most common is the de Jure classification. However, the de Jure classification is not reproducible. There are 11 studies out there saying that it's non-reproducible. So de Sure has, together with Lipasha, found out that if you use it as a binary classification, it's more reproducible, meaning either high or low. However, for scientific purposes and for daily clinical practice, the de Sure classification lacks something. So I think you should evaluate trochlear dysplasia on measurable parameters. And here we have the lateral trochlear inclination angle, the trochlear depth, the trochlear facet asymmetry, and the beaded anterior-posterior measurement, and there are several more. However, if you don't remember anything else from this presentation, please remember this, that trochlear dysplasia is localized proximal in the knee, most proximal, and the trochlear change from proximal to distal is more pronounced if there's trochlear dysplasia. And if you see on the picture see here, this picture here, this is the MRI and this is the actual X-ray of the same knee, tangential view. So don't use the X-ray to evaluate trochlear dysplasia. Use the MRI. Some of the characteristics, the decreased lateral trochlear slope, the decreased trochlear depth, and a medialized trochlear groove, meaning asymmetry, the elevated trochlear floor, that is the ventral prominence. The ventral prominence is on cartilage. It's actually the same as trochlear bump, but the trochlear bump is on bone. And then there can be medial hypoplasia of the condyle. The lateral trochlear inclination angle, we did a study and found out that among 33 measurements, this seems to be the most important measure for evaluation of trochlear dysplasia. And this is a new way to measure the lateral trochlear inclination angle, because this measure on two images. And if you see on the picture on the left, you see there are two different pictures, and that is how you're going to measure it. In daily practice, you check the MRI and find out where are the femoral condyles most prominent, as here. And then you scroll proximal and measure on the tangential line to the trochlear and measure the difference in between your posted and the trochlear. And this is a more reproducible than the old method. I tried to compare lateral trochlear inclination angle and the trochlear slope to the NASCARs. You know, NASCARs, they can go very fast in the track. Since the track is oblique, however, if the track is flat, there will be a tendency for the car to skid, and it's just the same with the patella. The trochlear depth can be measured this way. Normally it's 4.9 millimeter. If you measure on cartilage, if it's less than 3 millimeter, it's dysplasia. Then there's a facet asymmetry, and the important thing about the facet asymmetry is that it affects the TTTG. And some of you might use the TTTG as a guide for medialization of the tibial tubercle, but in most cases it's actually due to medialization of the trochlear groove, and I will come back to that later in my next presentation. So the patellar tilt, in most cases, patellar tilt is secondary to trochlear dysplasia. Since the lateral facet of the patella articulate with the lateral part of the trochlear, the patella automatically tilts. And if you do a trochleoplasty, what you will see is the patella suddenly comes down into the trochlear and the patella tilt disappear. Just to remind you that you can do a trochleoplasty. This was my last open trochleoplasty on the left, and then nowadays it's arthroscopic trochleoplasty, but that's another case. So there are still things we don't know about trochlear dysplasia. Which degree of trochlear dysplasia need a trochleoplasty? We don't know. And does it prevent erosion of osteoarthritis? We don't know. And what is the best trochleoplasty method? We don't know. trochleoplasty plus MPFL reconstruction better than MPFL reconstruction alone? We don't know. Can it reduce anterior knee pain? Some things say it might be so. There are 3 studies saying so, but there's a lack of evidence. Thank you.